Good afternoon, good evening, or good morning, depending on from when and where you're joining us. I'm Dr. Phoebe Thorpe, and it's my pleasure to welcome you to the CDC Public Health Grand Rounds for October 2019, Addressing Gaps in Healthcare for Individuals with Intellectual Disabilities. We have an exciting session, but first a few housekeeping slides. Public Health Grand Rounds has continuing education available. The course access code is PHG10. It's available till November 2021. Public Health Grand Rounds is available on all your favorite social media sites. Please send the questions to grandrounds@cdc.gov and we'll try to answer them during today's presentation. Want to know more? We have a featured video segment on YouTube and it will be posted to our website called Beyond the Data. This month's segment features a special interview between two of our speakers, Liz Weintraub and Dr. Tim Shriver. We also have partnered with the CDC Public Health Library to feature scientific articles. The full listing is available at cdc.gov/scienceclips. In addition to our outstanding speakers, Dr. Peacock, Dr. Haverkamp, Liz Weintraub, and Dr. Shriver, I'd like to take a moment to thank the individuals listed here. And here is a preview of our upcoming topics. Please join us live or on the web at your convenience. And now for a few words from CDC's Director, Dr. Redfield.
I'm CDC Director Dr. Robert Redfield. Welcome to CDC's Public Health Grand Rounds. I want to send my support and gratitude to all of you, CDC staff and partners, for your dedication to today's topic, intellectual disabilities. And thank you to our speakers for joining today. I'm proud to say that CDC is a science-based, data-driven organization. And the data tells us that 1 in 4 adults in our nation is living with a disability. That's more than 61 million Americans, plus their families. At CDC, data is also helping us better define and diagnose conditions, which will lead to better solutions in treatment to improve the lives of those impacted. Last, I'll say that CDC is a service organization. Today, you'll learn more about the health and healthcare impacts of those we serve. Again, thank you to all our partners for your commitment to individuals living with disabilities and their families and caregivers.
And now for our first speaker, Dr. Georgina Peacock.
Thanks, Phoebe. As the director of the Division of Human Development and Disability, I lead programs to improve health for people with and at risk for disabilities across the lifespan. As a clinician, I assist families to navigate healthcare and social service systems to improve health and quality of life. And today we'll be talking about improving health for people with disabilities. To begin with, I'd like to share some definitions. Developmental disabilities are a group of conditions due to an impairment of physical, learning, language, and behavior areas. They appear before 22 years of age, and examples include cerebral palsy, autism spectrum disorders, and intellectual disability. Intellectual disabilities are characterized by significant limitations in both intellectual functioning and in adaptive behavior, including many everyday social and practical skills, like understanding social cues, shopping, bathing, and protecting oneself. They appear before 18 years of age and are usually associated with an intelligence quotient of 70 or lower, and usually are included also in developmental disabilities. We estimate that about 7.4 million people in the United States have intellectual and developmental disabilities, and you will see different numbers. This is because of overlaps in definitions. Some people may have more than one diagnosis, and depending on the way we gather this data, or the data is collected, this number can be over or underestimated in people with intellectual and developmental disabilities. We also lack longitudinal data. National surveys such as the CDC's Behavior Risk Factor Surveillance System, or BRFSS, provide some information about the health needs of people with intellectual disability. BRFSS identifies people with disabilities through 6 questions, which includes one which identifies cognitive disability by asking about challenges with concentrating, memory, and thinking. Cognitive disability identified in this way likely includes intellectual disability, but the numbers may also include other conditions that don't meet the definition of intellectual disability, like dementia or mental illness. We currently are not able to separate the numbers for people with intellectual disability versus other cognitive conditions because the questions in this health survey are not specific enough. There are differences in obesity rates, in smoking, high blood pressure, and inactivity for people with cognitive disability and those without disability. The rates for all of these poor health outcomes are higher in people with cognitive disability. The Disability and Health Data System, or DHDS, uses BRFSS data, and it's an interactive tool on the CDC website that allows anyone in the public to access data on disabilities quickly and easily. The data are available at the state and national levels, and they give us a better idea of the health challenges faced and the costs used in healthcare settings for people with disabilities. We need these data to shape more targeted health programs that are effective for people with disabilities. Research to date suggests that people with intellectual and developmental disabilities are more likely to experience poor health outcomes, unmet healthcare needs, victimization such as sexual abuse, and early mortality. Analyses of South Carolina's Medicaid data showed that from 2001 to 2011, Medicaid members with intellectual and developmental disabilities had 21,000 potentially avoidable visits to the emergency department, which means they were seen in an emergency department for something that could have been treated in an outpatient setting, generating costs for over $35 million. People with intellectual and developmental disabilities are living shorter lives than those without. They die about 20 years younger than the general US population. At the same time, however, fortunately, people with intellectual and developmental disabilities are living longer than they did in the past. So there's a need to focus on improved healthcare and better outcomes. A growing challenge exists to address this population's unique health, service, and support needs. I'd like to transition now to discussing how we can use data that we have to improve the health of people with intellectual and developmental disabilities. CDC is actively using data to address healthcare needs of people with intellectual and developmental disabilities. And we do this by working with 19 state disability and health programs. This is critical since not all public health interventions are proven to work with people with all abilities. We have to ensure that they're inclusive. We also work with many national partners, including those listed here on the slide, and many more. As we move forward, we will continue to work with state, national, and federal partners to address the limited data available on people with intellectual and developmental disabilities. 2 reports have been developed in partnership with CDC's National Center on Health Statistics and the Administration on Community Living. One focused on identifying persons with intellectual and developmental disabilities in national population surveys, and a second examining data available on intellectual and developmental disability populations at both the state and local level. We will continue to use the data and information we have and are gathering to prioritize future research, such as further analysis of chronic conditions to develop effective programs that can target the unique health needs of people with intellectual and developmental disabilities and improve their health outcomes. And finally, in collaboration with partners, we can develop tools and resources to help train and empower individuals with intellectual and developmental disabilities, their caregivers, and healthcare providers to work in partnership to improve health. I'm honored to have opened this panel of esteemed partners who have dedicated both their professional and personal lives to bringing attention to and increasing awareness about the needs of people with intellectual disability in our communities. And now I'll turn it over to my colleague, Dr. Susan Haverkamp. Thank you.
Thanks, Georgina. I'm really pleased to be here this afternoon speaking with you about what we can do to improve healthcare for people with disabilities through education. I believe that education is the answer to disparities in healthcare because health education programs strive to prepare health providers to improve population health and to close healthcare disparities across different underserved populations. In fact, they teach students about health disparities, about patient-centered care and cultural competent care. The next generation of healthcare providers will be better prepared to meet the needs of a socioeconomically and culturally diverse population. However, people with disabilities represent one socially disadvantaged population that's been largely overlooked in these efforts. So that's what I'd like to talk with you about today. Before I begin, I'd like to express my gratitude towards CDC for supporting the Ohio Disability and Health Program. Without the support, this work that I'm talking about would not have been possible. 25% of the adult population in the United States has a disability. And as a group, we know that people with disabilities have high needs for health care. Now, I should say that what I'm talking about here is people with all different types of disabilities, from intellectual disability to mobility disabilities to mental health conditions and blindness, deafness. And the reason that I'm talking about people with disabilities broadly is because we know that healthcare barriers are quite similar across different disability groups, and furthermore that the healthcare training needs are very similar across different disability groups. And finally, because at 25% of the US population, people with disabilities warrant the attention of policymakers and health educators. So we know that people with disabilities face barriers to quality healthcare across all areas, all levels of the healthcare delivery system, from the societal level on down to the individual provider level. We know that we have inadequate data about the health of people with disabilities. If healthcare offices are often inaccessible and unwelcoming to people with disabilities, and individual providers, healthcare providers rather, often have low expectations for the quality of life and the health of people with disabilities. And those low expectations impair their ability to provide quality care. So I am not the first person to declare that education is the solution to healthcare disparities. Many experts have written reports and statements and position statements declaring that interprofessional health education has to address disability for the health needs of this population to be met. And when I say interprofessional, let me just define that term. I mean different disciplines in the healthcare delivery system: physicians, nurses, occupational therapists, psychologists, social workers, all different approaches to the healthcare population. There are incredible healthcare training programs that have been developed and to try to meet this need. The LEN training programs there's 44 of them across the country. They train interprofessional students to meet the needs of people with intellectual and developmental disabilities. The National Curriculum Initiative on Developmental Medicine creates and administers and delivers healthcare training programs for medical students on intellectual disability. The limitations of this approach to providing training is that it doesn't reach all students. For the most part, students self-select into these training programs, which may mean that the students who most need this education are the least likely to get it, and because they depend on a champion and external funding to keep these programs alive. What I'd like you to do is imagine a world where all students get disability training. All healthcare providers have a basic foundation of how to care for patients with disabilities. So people with disabilities have a range of health needs, just like people without disabilities. And in order for us to address health disparities in this population, it's important that all healthcare providers are trained to care for patients with disabilities. The Alliance on Disability in Healthcare Education is a nonprofit group. They ask a question, what is it that healthcare providers need to know about disability? What do they need to understand in order to provide quality healthcare? And they drafted a set of core competencies designed to train healthcare providers so that they have the basic understandings that they need to provide quality healthcare. That's another term I'll define. Competencies is a health education term. It basically means learning objectives that are used to develop curriculum. So what we did at the Ohio Disability and Health Program, we looked at the draft competencies that the Alliance developed, and we asked for broader input. We reached out to people with disabilities, family members, disability advocates, disability and health professionals, healthcare educators, healthcare providers, and we asked them to review the competencies and give us feedback. And then we took that feedback and incorporated it, revised the competencies, and sent it back out to the same group in kind of an iterative process until everyone agreed that these competencies are important and reflect what it is healthcare providers need to understand when caring for patients with disabilities. And we called that a consensus. Do you want to know what we found? So what we came up with was 6 core competencies and 47 sub-competencies. What I want you to understand about these competencies is that they're interprofessional. They're as applicable for future physicians, as future nurses, social workers, psychologists, and also that they're cross-disability, meaning that they form the basis of what providers need to know, whether they're caring for a patient with intellectual disability, mobility disability, mental health impairment, across the board. They're kind of the foundation. And I'll go through these competencies just briefly to give you a sense of what they are. And they're also available through me or on the website listed at the bottom of the screen. So the first competency, disability frameworks, we really thought it was important for future healthcare providers to shift their thinking from considering disability the root of the problem, something to be prevented and treated, to thinking about disability as just one aspect of the patient that doesn't limit their health or their quality of life. It's important for future healthcare providers to communicate directly with patients who have disabilities and to establish a rapport respecting the whole patient. Legal obligations and responsibilities are fundamental because healthcare providers must recognize that accessible healthcare, providing accommodations, is a civil right, not merely the right thing to do. Many people with disabilities have complex healthcare needs and benefit from care coordination among a team of healthcare providers. So students need to learn how to function as one member of an interdisciplinary team and how to keep the person with disability at the center of that team. Students should learn how to conduct a thorough health assessment that's accessible to people with disabilities, to provide appropriate accommodations. And finally, they need to understand that people with disabilities need age-appropriate screening, health education, family planning, end-of-life care just as anyone without a disability. And they need to learn how to provide accessible resources and the importance of promoting a healthy lifestyle, diet, exercise, managing health risks, just as with anyone else who doesn't have a disability. So those are the competencies. Before I close, I'd like to tell you about some work that we've done at The Ohio State University to offer disability training to medical students. And wonderful opportunities through the curriculum to offer opportunities for students to meet with people with disabilities, to interview them about their health and provide health care. And this is what the students are saying. They report that they feel more comfortable caring for patients with disabilities after this experience. They're better able to recognize their own assumptions and their bias in interacting with patients with disabilities and to challenge those assumptions and biases. And they're better able to consider people with disabilities as individuals and to treat them with respect and with candor. So finally, we have to include disability in the core competencies in all professional education standards for accreditation and licensure. When disability competencies are included in required education standards, then all health programs will include disability training, and all healthcare students will be prepared to deliver accessible, person-centered, quality healthcare to patients with disabilities. Including people with disabilities in healthcare training will improve healthcare for people with disabilities. Thank you. It's my pleasure to introduce Liz Weintraub. Liz is a senior advocacy specialist and the host of Tuesdays with Liz, Disability Policy for All.
Thank you. I'm Liz Weintraub, the Senior Advocacy Specialist and host of Tuesdays with Liz, Disability Policy for All, at the Association for University Centers on Disability, AUCD. Before I begin my remarks, I want to let you all know that I have an intellectual disability. I never went to college. I'm telling you this because I'm proud to be able to be making these points that are important to me and my friends with intellectual disability. I also want to thank you for including a person with an intellectual disability on this panel. I hope today we start making healthcare better for people with disability by using the expert people with disabilities. All people, and that includes people with disability, have the right to be healthy. Medical providers in the system must serve us. Having separate doctors and practices to serve people with intellectual disability doesn't make sense and makes us feel like we're special. We need to be able to find the care in our own community. When we get sick and need to see the doctor, we have the right to see a doctor that is appropriate for us, meaning an adult should not be forced to see a pediatrician just because we might have a disability. Doctors and system need to be accessible and allow for accommodation. People with disabilities should be able to make their own doctor's appointment and not always rely on a provider or a family member to make it for them. Other people with disability get sick more often than the general population because of our disability, and people deserve the chance and the dignity to get better. The medical professionals should not make the decision. Sometimes doctors will say to my friends, just because of their disability, the operation and the medication cost too much, and your life isn't worth saving because of your disability, and you can't contribute to society anyway. So we won't bother giving you the medication or performing the procedure. The person will most likely want to live. So we'll give the doctor any right to make a life or death decision for us. One of my favorite sayings is nothing about us without us. So that means if something is involving me, then I should be involved in the discussion, and that includes healthcare. My friends who are adults and I deserve the right and the dignity, the right and courtesy from the doctor and other medical professionals to be talked to directly, not through a support person or a family member. I'm the patient, and that means that I would appreciate if the doctor would talk directly to me. There are times that we are excluded from a discussion about our health care because the doctor or other medical professionals think it might make us upset, or we would not even understand the conversation and would take too long to explain things to us. This is wrong. I think people with intellectual disability deserve the right and the dignity to be involved in these discussions. If we don't understand, then it's important for someone to take the time to explain it to us in a way that would make sense to us. For example, last summer I was diagnosed with diabetes. Like anyone, I was scared and confused. My doctor suggested that I should go to see a nutritionist to help me figure out what I should and should not eat. So I asked my husband, who also has an intellectual disability, to go with me to support me when learning about the disease. The nutritionist was not patient with us at all. In fact, she talked to us in a way that we could not understand. So my family and I decided that nutritionist would not work for me. My family found another one that specializes in people with disabilities. However, it would involve too much time away from work to see her. Eventually, we're working with one of the nutritionists that we can understand and work with our schedule. The point I want to make is that we have our right to decide which doctor and provider makes the most sense for us. There are a lot of people that come into our life. Doctors, people who provide services to us, our families, and others. Not everyone should or even need to know my business. I might not want everyone to know everything about me. I might want some people to know something and others to know other things. I believe that people with disability have the right to decide who can know what kind of information and what type of information can we share. We deserve the dignity to be asked. I believe it is a good practice to bring someone along to some appointment so there's someone else to hear that information. However, everyone is different and every appointment is different. Some appointment I don't want or need my husband to come with me. He might not want me to come with him to his appointment. For example, I might ask a friend or a family member to come to an appointment rather than my husband, just because it might be involving female issues. We all have the right to decide who and if we would like to come. If anyone, we would like to come with us to an appointment. I'm here to say that people with intellectual disability doesn't need guardians, and we can make a decision for ourselves. We just need the time and the tools to help us understand how to make a decision. So, for example, people without disability need to explain things in a way that makes sense to us. We are all citizens of the United States, so therefore we all have rights. If people with disability have guardians, they will take time. If people with disability have guardians, they will take them away from us. We deserve the right and the choice to enjoy having sex just like any other adult. This is part of a full life. The medical world is part of supporting this. The medical world is part of supporting this with clear and good information. What I mean by this is that people with intellectual disability deserve the right and the dignity to be in control. That means to know and make decisions about their own health care. Note that I didn't say by herself. I don't believe that anyone makes decisions about their own health care on their own. We all need help. There's 3 resources. One, the National Independent Living Council, the statewide living councils, they just came out with a sex ed in plain language manual, which I would recommend. Another resource is the University Centers on Excellence in Developmental Disability at UCD, and South Africa Becoming Empower USA.org, and both of them have chapters all around the country to people with disability. I would encourage you to use them because people with disability need they can help you define health and things like that. And now it's my pleasure to introduce my friend Tim Shriver, who is the chair of the Special Olympics. Thank you.
Thank you so much, Liz. Thank you, Dr. Haverkamp. Thank you, Dr. Peacock. Thank you, all of the folks who have collaborated to bring us here. Dr. Boyle and many of you who've worked on Grand Rounds, Dr. Thorpe, we appreciate the chance to be part of this conversation. And all of you who are here live, I'm hoping you're here not just because it's more fun than being at your desks and watching on screens, but for us it's a huge honor, and your presence speaks volumes to the importance of this work in your careers and your professional commitments and your life purpose, I dare say. And on life purpose, maybe I can start with simply a pause moment. You've already heard in this presentation from Dr. Peacock and in the data that there are somewhere between 6.7, 7.5, 7.7 million people with intellectual disabilities in this country alone. And you've also heard one such person say these words that she's heard: "Your life isn't worth living." And she said them quickly, and she said them in some ways in a matter-of-fact way. But let that echo just for a moment in your experience. My guess is, without data, that probably every one of those 7.5 million people have heard that. Your life isn't worth living. And I am sorry to say that many of them have probably heard it from medical professionals. And they've also heard it from educators, and they've heard it from many others. So this is not to blame anyone. It is just to invite us all to recognize the gravity of this moment, this particular grand rounds, and this particular voice, and this particular invitation to pivot. As public health leaders, as healthcare practitioners, as citizens, as people who care about the future, who care about equal protection and these kinds of ideas, a moment, I dare say, to pivot. I hope no one leaves this room unchanged by those words. And I hope we all leave this room committed to understanding the importance of data, as you've heard, training, all the content that we've heard, but to remember that we are standing in the face of a very persistent and very ugly stigma that has been visited upon people who are innocent of any wrongdoing and who deserve much better by our country. So you may be thinking, what's the guy representing Special Olympics doing here at the CDC? He hangs around basketball games. Well, you're right. I don't have much business here, except that I have learned a lot at the hands of athletes like the one you're seeing here. Jacob came to our movement trying out in the state of Alaska to play basketball. We found that his blood pressure was 180/120. He had no doctor, he had no medications, he had a BMI of 31, 16 untreated cavities, and 2100 vision. This is not 1905 or 1805, this is today. This is the state of the art for someone who comes to our door to join a basketball team like any one of you might, to get fit, to meet friends, to compete, to enjoy themselves. And this is unfortunately how we arrive at this place where we get the honor to speak to you. We are inspired by Jacob. And you say, well, what's the history here? This is a photograph taken in the year 2001 in the state of Alaska also. On the far right of the picture is Senator Ted Stevens, who was at that time the chair of the Senate Appropriations Committee. He convened a field hearing. At the hearing was David Satcher, then the Surgeon General of the United States, several dentists and doctors who were volunteering in Anchorage, and several athletes. My mom is in this picture. You can see her on the left. Always like seeing pictures of my mom. And next to her is Loretta Claiborne. Loretta was raised in housing projects, a mom who had 7 kids plus foster kids and other kids who came through her house. She was labeled in the language of the day, a person with mental retardation. Her mom was encouraged and took her to drop her off at Eastern State Institution to live the rest of her life together with 7,000 to 10,000 other people with intellectual disabilities, and then took her home when she saw the place. So her mom was her first hero. Loretta was thrown out of childcare, thrown out of school, treated, I'd say, almost less than humanely. And she was at this hearing. She was a witness at the Senate Appropriations field hearing on the health status of this population. And she got up and said, after running 25 marathons and finishing in the top 100 women in the Boston Marathon, she chronicled the story of her life as someone who had been denied health care over and over and over and over again, how she couldn't afford a dentist, how her doctor didn't speak to her, as Liz has just said, over and over again. And then she said, you know, I got off the phone the other day with a friend of mine who's incarcerated. And he had just been to the dentist and had a full checkup. And she said, I don't know why I live in a country where my health care is worse than people who are incarcerated. And she stopped, and I don't know if you know this, but the rules of the Senate prohibit applause in public hearings. And notwithstanding Senator Stevens' adamant gavel, the place erupted in applause when Loretta finished. I share this story because here we have what I think is the shift in the paradigm of advocacy in the field of intellectual disability. For many generations, I would dare say, it was mostly moms advocating for the deinstitutionalization and the humane treatment of their children. But with Loretta and with Liz, as you've seen today, we have another kind of voice. The voice of data, the voice of self-advocates, the voice of data, bringing data to people in positions of power and influence when it comes to policy. And those voices all marshaled to demand change in institutions and service delivery systems. So it is no longer just a mom, or just a dad, or just a philanthropist. Now we have a new generation modeled by Loretta, which led us, the Special Olympics movement, to embark on this work of becoming an advocate for people with intellectual disabilities and their health. So people often say to me, when's the next Special Olympics? And I, depending on where I am, I can answer about 20 minutes from now. Because we're confused with the once every 2 year thing, right? It's Olympic, right? When's it coming up? May, June, this year, next year, even years, odd years? Okay, so in the United States, 30,000 games every year in this country alone. I wish I could put the global data up here, but we're focused on the US. This number is 4x when you add the rest of the world. Okay, so about 700,000 athletes participate in this movement every year. We have no longer a sports event organization, but a community-based health and wellness intervention that is aiming to capture and support people cradle to grave in sports, health, fitness, and wellness activities that increase their social competence and their social connection, increase their physical health, and increase their capacity to live meaningful and full lives. Now, if you look at the average team, we still do look like this. This is still our movement. Here's the rough data that we capture when we do these health screenings on site today. This is we can support this data with some existing data sets, but I hope you see in it the shocking health disparities facing people with intellectual and developmental challenges. 4 need a new prescription, 2 have eye disease, 1 almost invariably, somewhere between 10 and 16, sometimes as high as 18% of athletes, they get out of the pool, they've just got a medal around their neck, or they finish running the 200-meter dash or something like that, or the, you know, and then they walk into the screening and the doctor says, off to the emergency room. You have such severe disease in the oral cavity that you need emergency care. These are people who have been screened to participate. Okay? So we're talking about a deep stigma here, right? It's almost invisible in the healthcare system to many people, and this data, I think, shows why. So what are we doing? We've done over 1 million health screenings, meaning we invite all of you folks to come to games, set up a tent, set up an eye exam, set up an audiological booth, do physical therapy or occupational therapy, psychological screening, and help us identify where problems exist that haven't been identified and help with the referrals necessary to get those people high quality care. So in this, you see that almost 1,000 athletes have left these screenings and become trained, as Liz has done here today, as self-advocates, right? So they don't walk out waiting for Tim Shriver or waiting for some physician to advocate on their behalf. They walk out trained to become advocates, not just for their own health, but for the health of their peers who have an intellectual disability. Just over 50,000 are participating now in year-round health and wellness programs, nutrition, fitness, cardiovascular exercise, healthy sleep, smoking cessation, and on, these kinds of programs. And if you go then from the athletes themselves to the providers, we've already heard the mention of the challenge of training. Over 100,000 healthcare practitioners have received training in the clinical and sometimes in the didactic dimensions of intellectual disability by coming to the games. You all know this better than I do, but most healthcare professionals get more training in rare disorders or in rare procedures that they may never use in the course of their career. No offense, they should get trained, but they should more training in those kinds of things than they get in developmental disability. And if I were to ask by a show of hands in the healthcare professionals in this room, how many would feel competent in the quality of the training they'd gotten to serve and care for and do adequate referrals and diagnostics for people with intellectual disabilities, I fear, even in this room, that the number might surprise us. So, this is the model we used years ago after Senator Stevens said at the end of Loretta Claiborne's testimony. This is the model we used. He said, let's figure out how Special Olympics can help address these health disparities. You all will remember these vans when they were created almost 40 years ago, I suppose, to bring health care to the population that needed it. This is what we try to do. We try to bring partnerships, resources, and all kinds of assets to places where people with intellectual disabilities are. And so now we've extended this work with support from private philanthropy and from other local organizations to creating healthcare, what we call communities, right? So it's not one provider that we need. It's not one trained MD or PT or RN, or it's not one entry-level person we need in the system. We need communities of care where the entire public health system, in effect, combines its resources to create services and delivery systems that help support this. Now, you can see in this, for instance, that we have one in Nebraska. I'm happy to report I was just at Monroe-Meyer recently, where they're opening a whole new clinic in the Monroe-Meyer Institute called Caring for Champions, dedicated to cycling through medical students and all kinds of healthcare students, and also providing wraparound care. The same, my colleague, Dr. Alicia Bizzano, has the same kind of thing in Southern California at the Achievable Health Center. So we're beginning to see models emerge where mental health, physical health, and so on can be addressed in what we call healthy communities. So we've got challenges. You've heard about them already. The data challenges are significant. The quality measurement is significant. Incentivizing care is a significant challenge. In integrating physical and mental health is a challenge. You heard Liz talk about sexuality, also a challenge. We have so many ways in which we need to bring health to the community, training to the healthcare, data to the training, and training to affect change. We're here because we believe that your support in that regard is critical. So these are the kinds of easy first steps. We have legislation now introduced in Congress for creating a system where medically underserved designation can include people with intellectual disabilities. To me, it's a scandal that it hasn't for however long that's been in place. We have new training systems where medical professionals can take courses at learn.specialolympics.org. We can encourage people to come to these screenings, and we can encourage that kind of change. Here you have my final slide. It's an image of a child at our recent games, and you can see on his shirt, MATP, Motor Activities Training Program. This is a person who in medicine would be called someone with a severe or profound intellectual disability. Even today, people will say, well, this is a child who's not eligible for Special Olympics. Quite the contrary, quite the contrary. I've continued to find the greatest inspiration in our movement coming from athletes who overcome the greatest obstacles. To see an athlete like this, or hundreds of others I've seen over the course of my career, work for weeks and months to lift a bag, or lift a beanbag, or move a ball, or push a bowling ball, and achieve that, is amongst the greatest athletic achievements I've seen in my life. And I don't mean that LeBron James isn't a good athlete or Tom Brady, but none of them have anything in common, not even close, not even close. So Jacob, who you saw early on in these slides, like this athlete, is an athlete. He gets better. His BMI goes down. His blood pressure improves. These are human beings whose lives are worth saving. And I just thank Liz and my colleagues here and all of you for joining us, Dr. Redfield for inviting us to continue to tell this story and continue to pioneer new ways to end the discrimination that exists in our healthcare systems and promote a high quality of life for all of our brothers and sisters who have these enormously beautiful differences. Thank you very much.
So I think now we're ready for our question and answer time. And Susan, I think we'll start with you and see if there's any questions online.
Yes, we do have questions. I want to remind our online viewers to send their questions either via Facebook Live or to grandrounds@cdc.gov. So our first question from Tom: how do you decide when someone with intellectual disabilities needs a guardian?
We asked Liz.
Yeah, thank you, Tom. I really believe that there's no one who needs a guardian. We all need support, and there's a tool or a method. I don't know what you call it, but it's supported decision making. I think that if we poll people here, how many of us make a decision? Nobody would. If we talk about how many of you make a decision totally on your own, no one would raise their hand. We all need support from family, from friends, from doctors, from whoever. And we're no different. I might need some extra support because I don't understand this or that, or with my my diabetes, it was that I needed help with understanding things. It's really hard for me to understand financial help, so I would go and talk to my family about that. Well, I think that's pretty normal. And yes, I have a disability. I'm sorry, but we're no different than you are.
Hello. No follow-up here.
I have a question.
Hi. What do you think the biggest challenges are related to access to medical care for persons with disabilities, particularly young adults who have aged out of certain care systems, and what can CDC do to address those issues? Thank you.
Okay. Do you want to answer first?
In my opinion, the biggest challenge, I think this is on. Can you hear me? Okay. In my opinion, the biggest challenge is that healthcare providers are not trained and are not comfortable and are not competent to provide quality healthcare to people with disabilities. And I don't know what CDC, I'll turn it to Georgina to answer the second part of that question.
So I think within our division, we support disability and health state programs, national partners to look at data, for one thing, to look at the health needs of people with disabilities so that we can share that, and then also support the development of tools and resources to help healthcare providers understand how to care and treat, but with honor, people with intellectual disability.
Yeah, I'll just add very quickly, I think public awareness shifting out of what we variously call the disease paradigm or the medical paradigm into the social paradigm of disability is really important. And I think CDC has a long tradition of educating the public when we've got a problem in public attitudes. And the public attitudes in this case include healthcare practitioners. So I think we've got a big education shift to make, and I hope the CDC can help lead it. I would also just add that we've only begun to scratch the surface on telehealth and electronic diagnosis and critical capabilities being distributed electronically. We have many, many people in this big umbrella who have very rare distinctions, differences. There will never be the perfect training for all of them, but maybe there are ways to use remote diagnostic and professional, technical, I won't get the words right, but you know what I mean. We got to get the digital and e-health worlds to come to the rare challenges world and maybe bridge the gap between providers who are on the front lines and providers who have specific expertise in specific centers.
Another question online?
Yes. Laura would like to know if any of the panelists feel there are specific major legal barriers that we need to work on in terms of policy changes, especially at the state level, that would improve healthcare access for people with intellectual disabilities. What are policy changes that are needed at this point?
I'll try something. All right. Healthcare providers are disincentivized to care for patients with complex healthcare needs. Many people with disabilities have complex healthcare needs, require extra time for a physical exam, for an interview, and if they're reimbursed at the Medicaid rate, as many people with disabilities are, they cost healthcare providers more than they can recover in claims for the visit. One idea would be to work with the state Medicaid offices to negotiate an add-on, a higher reimbursement rate for patients with complex healthcare needs that would at least even the playing field.
I'd like to ask everybody to join me in thanking the speakers for an outstanding presentation. And please join us next month for Public Health Grand Rounds.